Hi everyone, it's Selena. I'm going to be going over the image evaluation for a routine hand exam, which includes a PA oblique and lateral projection. So first we're just going to go over some anatomy. So first we have the phalanges of digits 2 through 5, which include the distal, middle, and proximal phalanges, and these all have a head, body, and base. And then for the first digit, there's only a distal and proximal phalange. And then there are the metacarpals 1 through 5, and these also have a head, body, and base. And then we have the carpals, which I show up here a little bit more. So you have your hamate, triquetrum, pisiform lunate, trapezoid, trapezium, capitate, and scaphoid. And we have our joint, so in between the distal and proximal phalange of the first digit, you have the interphalangeal joint. And then between the distal and middle phalanges of digits 2 through 5, you have the distal interphalangeal joint. And then between the middle and proximal phalanges of digits 2 through 5, you have the proximal interphalangeal joint. And then for each digit between the metacarpal and proximal phalanges, there are the metacarpal phalangeal joints. And then in between the metacarpals and carpal bones, there are the carpometacarpal joints. So some of the things we're going to be going over are differentiating between different positions of the hand, which includes the 3 routine positions, which is the PA external, oblique, and the lateral. We're going to be identifying proper positioning of each projection based off of the evaluation criteria, and we are going to be identifying the anatomy that should be included in each position. So first we're going to talk about the routine exams. So for the Bontrager routine from the book, it is just a PA hand, an external or lateral oblique, and the fan lateral. For the Corwell routine, it is also the PA hand, external oblique, and fan lateral. But if there is any trauma or injury, we do include the internal or medial oblique as well. And we also do that if the exam is looking for arthritis. So patient history. So the patient came into the emergency room for a wound on the middle digit of their right hand. The patient's chief complaint was pain and tenderness around the site. So 4 views of the right hand were obtained to assess for possible fractures, dislocations, or foreign bodies at the site of injury. So first, the anatomy demonstrated for the PA hand. So the criteria is that the entire hand and wrist and about 1 inch of the distal forearm are visible. I said this was not met because it appears that less than 1 inch of the forearm or radius and ulna is visible, so the collimation should have been either opened a little bit more or the CR should have been moved down a little bit if the image was not centered correctly. So positioning for a PA hand. The long axis of the hand and wrist are aligned with the long axis of the IR. I put MET for this because you can see that the hand is right in line. The next criteria is that there is no rotation of the hand as evidenced by symmetric appearance of both sides or concavities of shafts of metacarpals and phalanges of digits 2 through 5, and the appearance of equal amounts of soft tissue on each side of phalanges 2 through 5. I said this was met because there is symmetric appearance on the sides of the phalanges and metacarpals on both sides, and there's no rotation seen in this image, and there's also equal amounts of soft tissue on both sides of the bone. This is just a reference image of a PA hand just to see what the equal concavities of the bone should look like. The next criteria for positioning is that the digits should be separated slightly with soft tissues not overlapping. I put MET for this because none of the soft tissues from any digits are overlapping. The next criteria is that the MCP and IPA joints should appear open, indicating correct CR location, and that the hand was fully pronated. I said MET for this because all joint spaces are clearly open in this image. The next criteria is that the CR and center of collimation field should be to the third MCP joint, which is right here. I said not met for this because the CR is slightly above the joint, and if it was moved down a little bit to the third MCP joint, it would have included a little bit more of the distal forearm without having to open up the collimation more. And then I do just have the reference image here again just to show the joint spaces and how they should appear to be open. So next we have the exposure. So the criteria is that the optimal density or brightness in contrast with no motion demonstrate soft tissue margins and clear, sharp, bony trabecular markings. I said met for this because there is no motion seen on this image and the bones and soft tissue all have sharp markings. And in order to achieve this, you want an SID of 40 inches and your KVP range should be between 55 and 65. So then we have the anatomy demonstrated for the external or lateral oblique hand. So the criteria is that the entire hand and wrist, about 1 inch of the distal forearm, are visible. I said not met for this because 1 inch of the distal forearm is clipped. For the positioning, the first criteria is that the long axis of the hand and wrist should be aligned with the IR. I said not met for this because the hand and wrist are at a slight angle compared to the IR, which is straight up and down. The next criteria is that a 45-degree oblique is evidenced by the midshafts of the metacarpals should not be overlapping. Some overlap of distal heads of the 3rd, 4th, and 5th metacarpals, but no overlap of the distal 2nd and 3rd metacarpals should occur, and excessive overlap of metacarpals indicates over-rotation, and too much separation indicates under-rotation. I said not met for this because metacarpals 3 through 5 are overlapping, which is indicating over-rotation of the hand. The next criteria is that the MCP and IP joints are open without foreshortening of mid-phalanges or distal phalanges, indicating that the fingers are parallel to the IR. I said not met for this because the hand and wrist were not aligned with the IR, causing the joint spaces to not appear as open as they should be, and I see that more around the PIP joints of digits 2 and 3. The next criteria is that the CR and center of collimation field should be at the 3rd MCP joint. I said not met for this because the CR should have been moved down to the 3rd MCP joint, and this would have ended up including the distal 1 inch of the forearm as well. So the exposure for an external oblique hand, the optimal density or brightness in contrast with no motion demonstrates soft tissue margins and clear, sharp, bony trabecular markings. I said this was met because there is no motion evident in this image and all bones and soft tissue margins are clear. And in order to achieve this, you want an SID of 40 inches and a KVP range between 55 and 65. The anatomy demonstrated of a lateral hand. So the criteria is that the entire hand and wrist and about 1 inch of the distal forearm are visible. I said not met for this because there appears to be more than 1 inch of the distal forearm visible, and the fingers or the digits are close to the top of the collimation field, and the CR probably could have been dropped down or pulled up a little bit. So positioning for a lateral hand, the first criteria is that the long axis of the hand and wrist should be aligned with the long axis of the IR. I said not met for this because while the digits do seem to be aligned with the IR, the wrist and forearm do appear to be at a slight angle compared to it. The next criteria is that the fingers should appear equally separated with phalanges in the lateral position and joint spaces open, indicating that the fingers were parallel to the IR. I said met for this because all fingers are separated and the phalanges are all in a lateral position, which can be seen by the concavity on one side of the fingers. and the joint spaces do appear to be open on all digits as well. The next criteria is that the thumb should appear in a slight oblique position, completely free of superimposition, with the joint spaces open. I said met for this because the thumb does appear to be in a slight oblique and the joint spaces are open. The next criteria is that the hand and wrist should be in a true lateral position, as evidenced by the distal radius and ulna superimposed and the metacarpal superimposed. I said not met for this because the metacarpals are not all superimposed, and neither is the radius and ulna. The radius is seen to be anterior to the ulna, and this shows that there is insufficient rotation, and the hand should have been externally rotated a little bit more to be in a true lateral position. The last criteria for this is that the CR and center of collimation field should be at the second MCP joint, which is right here. And I put not met for this because the CR should have been raised slightly to the second MCP joint, and this also would have exposed less of the distal forearm because there is a little too much in this image. The exposure for a lateral hand. The optimal density or brightness and contrast with no motion demonstrates soft tissue margins and clear, sharp, bony trabecular markings. I put met for this because there is no motion evident and all soft tissue markings do look clear, and this can be done by using an SID of 40 inches and a KVP range between 55 and 65. The next criteria is that the outlines of the individual metacarpals demonstrated are superimposed. While you can see the outlines of the metacarpals, they are not superimposed on top of each other, so I did put not met for this. And the last criteria for this is that the midphalanges and distal phalanges of the thumb and fingers should appear sharp and maybe slightly overexposed. I put met for this because the phalanges and midphalanges do appear sharp, although they do not seem to be overexposed, but that does not happen in every image. So now we have the radiology report. So the findings were that there is no displaced fracture, dislocation, or radiopaque foreign body identified. There is mild multifocal osteoarthritis, and the impression was that there's no displaced fracture. While there were no pathologies seen from the site of injury, I just wanted to review a couple of the things mentioned in the report. So I wanted to talk about the osteoarthritis, which is just breakdown of joint cartilage that causes joint pain, stiffness, and loss of mobility. And then I just wanted to talk about the fracture since that was mentioned, and that is a complete or partial break in a bone that can be caused from a trauma, overuse, or diseases that weaken bones, such as osteoporosis. So, to close out, I just wanted to review what we went over in this presentation. So, we went over how to differentiate between each position of the hand during a routine exam based on the anatomy demonstrated. We identified proper positioning in each projection based on the evaluation criteria, such as the obliquity of the hand in a 45-degree oblique and under and over rotation, and kind of how to be able to tell if, like for the lateral, how the radius was anterior to the ulna. You can see from there that you need to be externally rotated a little bit more to be in a true lateral. We also identified anatomy that should be demonstrated in each position, and we evaluated the proper collimation and centering for each projection. And then these are just my references, and that's it.